This presentation on schizophrenia spectrum and other psychotic disorders is by Kimberly Bennington and Adam Rowland. I'm doing part one of the presentation, which includes schizophrenia diagnostics, theories on causation of schizophrenia, and the effects schizophrenia has on families and caregivers. Key features that define the psychotic disorders and abnormalities in 5 domains in the DSM-5 are 1. Delusions, which are fixed beliefs not open to change, even when evidence contradicts them. They're termed bizarre, implausible, and not derived from ordinary experience. 2. Hallucinations, which are involuntary sensory experience not related to external stimuli. 3 are disorganized thinking and speech patterns, derailments of focal topic, or loose associations or incoherence. 4 is grossly disorganized or abnormal motor behavior, including catatonia. 5 is negative symptoms, which are reduced emotional expression, avolition, alogia, anhedonia, and asociality. Subtypes are schizotypal personality disorder, delusional disorder, brief psychotic disorder, schizophreniform disorder, schizophrenia, schizoaffective disorder, substance and medicated induced disorder, psychotic disorder due to another medical condition, and catatonia. Schizophrenia diagnostic criteria encompasses several distinct criteria, and A is 2 or more of the following present for a significant portion of time in a 1-month period, less if successfully treated. At least one of them must be one of the first 3 from the 5 domains, and those, as a reminder, were delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, negative symptoms. B, for a significant portion of time since the onset of the disturbance, a person's level of functioning in one or more of the major areas of their life, this would include work, relationships, self-care, shows markedly below normal achievements prior to the onset of when the symptoms started. Or if the onset is in childhood or adolescence, there must be a failure to achieve expected levels of interpersonal, academic, or occupational functioning. C is continuous signs of the disturbance persisting for at least 6 months. This 6-month period must include at least 1 month of symptoms, less if successfully treated, that meet criterion A. As a reminder, this would be active phase symptoms and may include periods of prodromal or residual symptoms. During those prodromal or residual periods, signs of the disturbance may be manifested by negative symptoms or by 2 or more symptoms listed in criterion A present. And this would be in an attenuated form, such as odd beliefs or unusual perceptual experiences. D is schizoaffective disorder and depressive or bipolar disorder with psychotic features having been ruled out because either, number 1, there were no major depressive or manic episodes occurring, and that would be having occurred concurrently with the active phase symptoms, or 2, if mood episodes have occurred during the active phase symptoms, but they've been present for a minority of the total duration of the active and residual periods of the illness. E, the disturbance is not attributable to the physiological effects of a substance. This would be a drug of choice or a medication, or there's another medical condition that is present. If there's a history of autism spectrum disorder or a communication disorder of childhood onset, the additional diagnosis of schizophrenia is only made if there's prominent delusions or hallucinations associated, in addition to those other required symptoms of schizophrenia that are present for at least 1 month or less if successfully treated. Schizoaffective disorder diagnostic criteria includes an uninterrupted period of illness, which there's a major mood episode, and that would be major depressive or manic episodes concurrent with criterion A of schizophrenia. It must be noted and acknowledged that the major depressive episode must include criterion A1, which is depressed mood. Delusions or hallucinations for 2 or more weeks in the absence of a major mood episode. That means depressive or manic episode during the lifetime duration of the illness. Symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness, and the disturbance is not attributable to the effects of a substance Once again, that would be a drug of abuse or a medication or another medical condition that's present. Schizophreniform disorder criterion includes A, two or more of the following, and once again, these are going to be present for a significant portion of time during a 1 month period, not as long if successfully treated. One of them must be one of the three of the first 5 domains, and those 5 domains, as a reminder, in order are delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, or negative symptoms. B, an episode of the disorder will last at least a month but less than 6 months, and the diagnosis must be made without waiting for recovery. It should be qualified as provisual when that occurs. C, schizoaffective disorder and depressive or bipolar disorder with psychotic features have been ruled out, and they've been ruled out because either there's 1, no major depressive or manic episodes occurring concurrently with the active phase symptoms, or 2, if mood episodes have occurred during active phase symptoms, they've been present only for a minority of the total duration of the active and residual periods of the illness. And D, this disturbance is not attributable to physiological effects of a substance. As a reminder, this means drug of abuse or a medication or another medical condition is attributed. Schizoaffective disorder is an uninterrupted period of illness during which there's a major mood episode. That would be major depressive or manic episode, and that is also concurrent with criterion A of schizophrenia. It must be noted the major depressive episode must include criterion A1, which is depressed mood. B, there are delusions or hallucinations for more than 2 weeks or more in the absence of a major mood episode. That mood episode will be, that's depressive or manic episodes during the lifetime duration of the illness. C, symptoms that meet criteria for a major mood episode are present for the majority of the total duration of the active and residual portions of the illness. And D, the disturbance is not attributable to the effects of a substance. As a reminder, this would be a drug of abuse or medication, and there's not another medical condition that is present. Delusional disorder criterion includes A, the presence of 1 or more delusions, and this would be having a duration of 1 month or longer. Criterion A for schizophrenia has never been met. It must be noted that hallucinations, if present, aren't prominent and are related to the delusional theme, such as the sensation of being infested with insects, and that can be associated with delusions of infestation. C, apart from the impact of the delusions or its ramifications, functioning is not markedly repaired and behavior is not obviously bizarre or odd. D, if manic or major depressive episodes have occurred, these have been briefly relative to the duration of the delusional period. E, the disturbance is not attributable to the physiological effects of a substance or another medical condition and is not better explained by another mental disorder, such as body dysmorphic disorder or obsessive compulsive disorder. Brief psychotic disorder criterion include A, presence of 1 or more of the following symptoms. Once again, this is going to be at least one of those first 3 of the 5 criterion. That would be delusions, hallucinations, or disorganized speech. And lastly, grossly disorganized or catatonic behavior for brief psychotic disorder. Note, we're not going to include a symptom if it's culturally sanctioned response. So if it's a normal cultural thing that someone is experiencing due to their surroundings or environment and their cultural upbringing, we are not going to include a symptom. B, durations of an episode of the disturbance is at least 1 day but less than 1 month, with eventual full return to premorbid levels of functioning. And C, the disturbance is not better explained by major depressive or bipolar disorder with psychotic features or another psychotic disorder such as schizophrenia or catatonia, and is not attributable to the physiological effects of a substance. As a reminder, this means a drug of abuse or a medication, and there's not another medical condition present. Other disorders include catatonia associated with another mental disorder, catatonic disorder due to another medical condition, other specified schizophrenia spectrum and other psychotic disorder, unspecified schizophrenia spectrum and other psychotic disorder due to another medical condition, and substance and medication-induced psychotic disorder. Theories on causation. Genetically speaking, schizophrenia and other psychotic disorders are heterogeneous. Symptomatically, Their severity is a predictor of illness and its various forms, and that can come in the forms such as degrees of cognitive deficits or degrees of neurological deficit. And the genetics and the environment also can be predictors of schizophrenia, is important to be noted. Research shows it takes a combination of genetics and your environment to trigger the disease. Our genes are comparable to a blueprint, like we all have a blueprint for our bodies. If there's a change in what the instructions are calling for, this can sometimes increase the odds for developing diseases like schizophrenia. Doctors think it takes many genetic alterations or mutations to raise a person's chances of having the mental illness schizophrenia. Doctors know that if a person is more likely to get schizophrenia, it's a result because someone in his or her family has it. If that person is a parent, brother, or sister, their chances are increased by 10%. If both their parents have schizophrenia, a person has a 40% chance of getting it also. The area where there's the greatest chance of a person getting schizophrenia is when they have an identical twin who has schizophrenia. If this happens, a person's chances of getting schizophrenia are increased by up to 50%. On the other hand, there are some individuals who have no familial history of schizophrenia. The environment has certain viral infections that if someone are exposed to them before birth, it could increase chances of getting schizophrenia. And this can be true if an individual's birth mother didn't provide proper nutrition while she was pregnant also. This is especially chancy if during the first 2 trimesters of the pregnancy, the nutritional value levels were low. Studies show that taking certain mind-altering drugs, psychoactive or psychotropic drugs such as methamphetamines or LSD, can also make schizophrenia more likely to occur. Some research has shown that marijuana use has a similar risk. The younger you start and the more often you use these types of drugs, the more likely you are to have symptoms like hallucinations, delusions, inappropriate emotions, and trouble thinking clearly. Schizophrenia in your brain has been found to be able to show signs of deficiency. Experts have found that brain images of people with schizophrenia are different from normal brain images. In an individual with schizophrenia, they found spaces in the brain called the ventricles that were larger, parts of the brain dealing with memory, which is the medial temporal lobes, were smaller, and there were fewer connections between brain cells. People with schizophrenia also tend to have differences in the brain chemicals called neurotransmitters, and these neurotransmitters are responsible for communicating the information in the brain itself. Further studies of brain tissue in people with schizophrenia after death have also shown their brain structures often much different than it was at birth. There's quite an impact on families, and families can either, in some areas, be helped or hurt by loved ones experiencing schizophrenia. So schizophrenia can have a tremendous impact on those caregivers, which are usually family members. Gator et al. Found in their qualitative study with 19 informal caregivers that this impact can entail many of these types of things. And this was accomplished through their face-to-face, open-ended, semi-structured interviews with those 19 English-speaking informal caregivers. In order to ensure they had a representative sample, the criteria that was extensive was at least 2 caregivers would be of people with each DSM-4 characterized schizophrenia subtype. At least 5 caregivers would be of people experiencing schizophrenia with severity scores of 4, 5, and 6. There would be at least 4 males and 4 female caregivers to those people suffering from schizophrenia. There were at least 6 gender-matched caregivers, as well as 6 mismatched caregivers. Mismatched caregivers could be male-female, friends, relatives, not necessarily direct family members. There were 6 caregivers less than 60 years old and 6 caregivers who were more than 60 years of age. And 20% of the caregivers had an education level that did not go beyond high school. Qualitative results from the study found many things. The numbers affiliated with each aspect refer to the number of caregivers who discussed each concept and for whom the concept was relevant. There were practical advantages such as patients helping with housework, clarification of the disease, increased life perspective. There was enjoyment through shared fond memories and companionship with those they were caring for who had schizophrenia. On a personal level, there was better understanding of mental illness, greater life satisfaction and reward. They found they had greater patience and exponential love for those they were caring for. Relationships between caregivers and their loved ones found that persons with schizophrenia had increased patient-centered lives and positive personality changes. Outside of the home, caregivers found there was deterioration of their outside friendships. They avoided social situations. Increased stigmatization was mentioned, and there was a loss of social life. On a family spectrum, there was neglect of other family members seen. Strains on familial relationships was a problem as well. Finances and employment opportunities of caregivers can suffer greatly. Schizophrenics often depend financially on their caregivers. Cost of treatment and care can be burdensome and expensive. More work hours due to tremendous amount of time needed to care for those with schizophrenia. On the other hand, often reduced outside work hours occurred because of the amount of time spent taking care of individuals having schizophrenia. Sometimes there was difficulty maintaining work and caregiving balance, ceased employment because it became too much for them to handle both. Some caregivers even changed their professions entirely in order to accommodate the needs of the loved ones they were caring for experiencing schizophrenia. Caring for someone with schizophrenia causes a lessening of a caregiver's normal daily activities. This can be due to increased responsibility for medication administration, more doctor's visits, less time for other responsibilities, and less time for oneself. There were several caregiver concerns identified. Caregivers who worried about their future, especially their finances, and their ability for continued caregiving. They worried that if they got sick or died, who would take care of their loved one? Disturbing and violent behaviors by those they cared for was sometimes a problem. This also kind of panned into potential relapse and what the next episode would bring, what they were going to have to face the next time their loved one had a relapse. They worried about patient safety more so than their own. They were concerned about other family members and friends as well, and unpredictable behaviors by the person with schizophrenia. There's a physical aspect of what caregivers experience, and this included increased stressors in their lives, sleep disturbances related to everything that was happening around them, more tiredness than would normally be felt, feeling more emotional, greater bouts of sadness, and some of them felt anger that they were having to deal with this. They also were more frustrated than before, guilty for not having mental illness themselves or for ways they may have handled something in the past with their loved one. Some caregivers were embarrassed by the one they cared for who had schizophrenia. Some caregivers mentioned isolation, spoke about depression. There was felt inadequate, like they were lacking what was necessary to do a good job in their caregiving. And many felt overwhelmed by all the demands of being a good caregiver and what that entailed. This preliminary conceptual model does not seek to convey the strength, direction, or nature of relationships between the concepts and domains. What the future research will entail will cover some of those areas. This is a table where it talks and shows the caregiver impacts felt by those caregiving roles when dealing with persons with schizophrenia symptoms. Here are the references I used for part 1 of the presentation, and now on to part 2 of the presentation.